Thank you very much. It's a great honor to be here. Thank you to the organizers for inviting me. I'm from Cincinnati, Ohio in the USA. We do have a little bit of fat to harvest in our area. I know that some of the moderators mentioned that earlier, that it can be a challenge, and certainly it can be. But most of the time you only need, I find, 20 to 30 cc's, maybe 60 of infiltration at the most. So it doesn't take that much even in a pretty thin patient. So even though the title was filler versus fat, I'm focusing on fat because that's the topic of this section. So with aging, we see not much descent to the brow, but I want to focus on the volume loss that occurs around the eye, the supraorbital hollowing that occurs, as well as the infraorbital hollowing that occurs. And if you were here earlier for the very nice panel that they had, that was much of the emphasis was on the infraorbital area. I'd like to challenge everyone to consider injecting the supraorbital area as well. I think it's a very gratifying area to infiltrate, particularly if you look at how the supraorbital hollow in the patient's younger half on our right. It's not a high brow, and it's just a full brow comprised of highlights. So nice diagram. It just happens to show the infraorbital region, and you notice that absent is any change in the supraorbital area. In fact, it might even look better in the lower one. But anyway, as far as the infraorbital region, you get, of course, pseudoherniation of the lower lid fat through weakening of the orbital septum, and volume loss in the midface, bony and soft tissue volume loss, which contributes to this kind of double contour or sulcus area. Well-known actress who in the picture on the left is still quite young and has nice highlights around the eye, and then on the right side she's begun to show some hollowing, particularly in the medial supraorbital, medial infraorbital areas. And it does seem to begin medially and extend laterally, the volume loss. So if we then artificially enhance the hollows and turn them into highlights, I think it presents a more youthful appearance on the right. So the periorbital region, I break it down into supraorbital and infraorbital regions, medial and lateral in each case. In particular, in the infraorbital region, we focus on medial and lateral deep, and then also go superficial where the dots are. That's the maximum depth of the infraorbital hollow, and that's where I focus on filling superficially. We typically blend into the temple and cheeks. Frequently, the temple, almost always the cheeks. In lateral acanthus, it's not marked here, but frequently that's filled as well. She is marked for an upper lid blepharoplasty as well. And so it is easy to combine with other procedures, as we'll show. Advantages of fat: it's natural. Patients frequently love the au naturel thing. It's durable in my hands. I have my own 8-9-year results, which I'm very pleased with. I just saw a patient this week who's 3 years out, who's thrilled, 1 round. There's no Tyndall effect. I love doing HA fillers, but in order to get a great result, I feel like I have it in my own eyes, and I can see a little hint of bluish underneath my eyes. But in order to get what I think is a pretty perfect result, you frequently have to go more superficial, and then you're at risk of a Tyndall effect or bluish effect, which you have to either cover with makeup or manage with whiteys or hyaluronidase. So fat doesn't have that characteristic. There likely is a stem cell effect, I think, which is a source of stem cells in the body, body weight, and in an animal model has shown increased dermal thickness through collagen growth in the skin. It's also easily combined with other procedures. I rarely do it as a standalone. I will, but rarely is it done as a standalone. Frequently it's combined with brow lift, upper lid blepharoplasty, lower lid blepharoplasty, and facelift. Disadvantages: main thing is the downtime. Not a lot of patients love the idea of a second week of downtime. Those that do are very happy with it. So I usually tell patients 10 days to 14 days until they're kind of not going to scare anybody by the amount of fullness that they have. Predictability, not as far as asymmetries or lumps or bumps. That's happily not been our problem. I'll prove. We're pretty particular about how slow we inject and the planes and everything. So the only predictability issue is the percent retention, and it does tend to vary with patients. So the other thing is it's challenging in very thin patients, marathon runners, and in older patients. Our particular technique, we harvest with a 10 cc syringe. I try to make sure there's no more than, show there, no more than about 2 cc's of back traction on the syringe, on this 10 cc syringe, so more than 2 cc's of vacuum. I know some people use a Johnny lock. I don't, because I'm worried about that. I haven't tried it and seen that there's more fat loss or that there's decreased retention, but I'm worried about that. And just take it out diffusely, and you don't get lumps or bumps in the donor area. I use a 3 millimeter cannula with 3 side ports. We process it. I do centrifugation, 3,000 RPMs, 3 minutes. Get rid of the top and bottom layers, keep the fat. This has been talked about before. And we transfer to 1 cc syringes, as shown here. We infiltrate with 0.9 and 1.2 millimeter cannulas. Mainly the 1.2 is for the infraorbital rim deeply, multiple planes in small amounts. So just a quick video showing palpating the infraorbital rim in infraorbital neurovascular bundle to try to minimize damage to that, try to prevent infiltration into that, starting medially and extending laterally for the deep injection. Again, this is with 1.2 cannula. I'll just skip ahead. And then, sure. Okay. Sorry about that. And then extending more laterally, also in the deep plane, near the periosteum. Some people instruct you to inject right on the periosteum. I'm worried that if you're right on periosteum, particularly in the infraorbital neurovascular bundle region, that there's risk of damage to that. And then this is more. This is a much more quick injection. This is a superficial one. Less concern about the neurovascular bundle there. Superiorbital rim, then we start medial and then go lateral. We use an injection right up in the about parallel vertically with the pupillary line, protecting and feeling with the non-dominant hand, stabilizing the skin too, because you do have to pass through some small septations. So injecting from this area right here into the medial supraorbital area. Don't need to belabor that. We do get fairly close to the, as we can see here, she's had an upper lid blepharoplasty, and so we get as close as possible to that upper lid sulcus, and then inject only on withdrawal. That's true for every area, certainly around the eyes, injecting only on withdrawal to minimize intravascular injection. Lateral supraorbital rim, injecting from the lateral approach, right over in this area, probably about down in this area, just about in the lateral canthal area. This is the second of 2 that I've done in this patient, and so it's a little bit more quick, and I'm tapering into the forehead and temple. Okay. And then some examples. So I'll just go through some kind of mild, moderate, and more marked atrophy and show what's worked well for us. So this patient in her 50s asked for facial rejuvenation. She actually had a facelift concomitant with the fat transfer, no blepharoplasty. And we used 1 cc in each medial and lateral deep area, 1 cc superficial in the infraorbital rim, 0.2 for lateral acanthus, and then 3 and 2 for the anterior and lateral cheek, respectively. And I was very pleased with the result, as was she. She has favorable anatomy anyway. It's not like, this is not the more challenging facelift patient. A little more challenging, moderate atrophy. You could argue she could use a brow lift. I would agree with you. In this case, upper lid blepharoplasty, periorbital fat transfer, and deep plane facelift. And we used same amounts, one medial and lateral deep, 1 superficial, 3 anterior and lateral cheek. We actually did 2 in the temple for this patient, and we did do 1 cc medial and lateral supraorbital rim. And I think that's a nice improvement of the highlight beneath her brow. Another patient with sort of moderate atrophy, facelift with fat transfer in the periorbital region. Went up to 1.5 cc's in the superficial injection. When I say superficial, this is probably not in or above the muscle. It's just not near the periosteum. I've tried to, on occasion, inject more superficially than that. I don't like that, trying to inject into or above the muscle. Mainly, there was some prolonged bruising, which led to, I think, hemosiderin staining. Thank you. Just a few left. Again, moderate atrophy, just a recent patient. She's only a month out. I just saw her last week. One medial lateral superior orbital rim, same thing on the bottom as the last patient, except only one superficial. And then more marked atrophy, 2 superior and lateral supraorbital rim, 2 superficial in the infraorbital rim for this more advanced hollowing of the upper lid. I would wonder whether anybody would consider doing a brow. She had not had a brow lift before, but certainly in my hands, a brow lift would be the absolute wrong thing for me to do on her. So I'm very happy with the reduction of the supraorbital hollow that she has. More youthful overall. The key things, improvement without overdoing it. So you can always go back and inject a little HA filler. You can always do another round of fat transfer. This is after 1 round. She was very happy with it. In guys, of course, be more conservative. They don't want the Vogue cover cheeks. So in this gentleman, actually, it was more difficult to harvest fat anyway, but I was only planning to do the infraorbital rim with the lower blepharoplasty, so just 1 cc in each area in the infraorbital rim, medial and lateral deep and superficial. And same with this gentleman, lower blepharoplasty with fat transfer. We did just do a little bit in the cheeks, 1.5 and 1 cc. So be very conservative, I would say, in the male cheek, so you don't feminize them unless they're looking for that. Okay, so in the future, hopefully PRP and stem cells are going to be further tailored to allow us to enhance our results, mainly by reducing the amount of fat that we're injecting and therefore reduce the downtime. That's been the biggest challenge. Irregularities just haven't been my problem, and I've been doing it for 9 years now.